Hello, welcome back. This week we're going to be discussing Chapter 4, which is reimbursement methodologies. I have some additional material on HCCs that I think you'll find interesting, as more than 35% of Medicare patients in the state of Oregon are now covered under a Medicare Part C plan. Let's take a look at reimbursement methodologies. Okay, as discussed, we're going to be talking about healthcare reimbursement methodologies. We'll talk about retrospective versus prospective, pretty straightforward, but has some little nuances to it. We'll talk about how diagnosis coding is used in risk-adjusted models. This will come up again with the additional material I have for HCCs and Medicare Part C. We'll also talk about how accountable care organizations combine reimbursement methodologies to create a somewhat hybrid payment system. Retrospective versus prospective is pretty straightforward. This is a kind of fee-for-service model that we're all familiar with. We go to a physician, they order tests, they have labs drawn, they provide an exam of varying levels of complexity, and it's based on what resources were actually expended. We don't really know what's going to be done until we go to the physician, right? Makes sense. We don't know what labs are going to order. We don't know have any idea what type of cost will be attached to it. And the risk is on the payer because the payer costs are unknown until every service, every test, every result has been processed. So it's looking backwards. Prospective is meaning that the provider gets a predetermined amount for all services. So in the HCC model, if a patient has peripheral vascular disease, and HCCs are a category of diseases, right? So those that have peripheral vascular disease would fall into HCC 135. The insurance company, the payer, if you will, would get a predetermined amount from CMS for all services, whether the patient was seen once in a year or 200 times in a year. The provider faces a fiscal loss if the costs of the services provided exceed the reimbursement. The provider, however, can profit if the costs are less than the reimbursement. The risk is more on the provider side because the payment rates are established in advance and they're fixed for a specified time frame, a year or what have you. The retrospective payment model has a fee schedule, and this is basically a list of fees attached to HCPCS, CPT codes, what have you, that allow for a payment for these types of services. And again, we don't know what's going to be charged until all the services are rendered. The payers negotiated to pay a reduced fee for the services provided for the insured person. So in our example here, payer A pays 70% of billed charges for chemotherapy. So if the charge is $1,000 for a one-day stay in a chemotherapy suite, the reimbursement is going to be $700. When we use the term per diem, this is a fixed rate for each day that somebody is in the hospital. And we see a lot of this in the fee-for-service world with hospitals. We have a fixed rate that talks about the type of a room. An ICU will be more than a general surgery or general medicine bed and so on. And the contracting unit is an inpatient day. That's why we're interested in census. And it's retrospective because once somebody's admitted, we don't know if they'll be staying 1 day, 7 days, or what. So it's unknown until the patient is discharged. With capitated patients, the payer is going to reimburse a provider a fixed amount per capita for a defined period. So this is per member per month, right? And whether similar to the HCC model, it doesn't matter if the patient comes in one time a month, or 30 times a month. The provider will be paying the same. And the providers can do things to control this by engaging in population health and care management programs and some of these other things. With the prospective case rate, the payer is going to reimburse the provider one amount for the entire admission or the encounter, regardless of the number of services or length of admission. And the contracting unit is the encounter instead of with the retrospective where it's the patient, right? The providers can either earn a profit or a loss based on whether the cost of providing care exceeds the reimbursement or not. Another thing we see with prospective payment and something that comes up is global payment. So we have one combined payment to cover all the services for all the providers who involved in a single episode of care. And so for outpatient dialysis, we get one global payment. We don't have every line item out there. When we talk about bundled payments, we're talking about all different services that are provided in one episode of care. It's one lump sum payment. So a lot of times a service or onset of condition episodes initiates a certain episode of care, such as Sloan Kettering or MD Anderson head and neck cancer bundles. With the retrospective payment model, which is our traditional fee for service, we see a few things going on here. Number one, there's really not a whole lot of incentive to control cost. There's really not a whole lot of incentive to order less expensive tests, right? And all tests eventually have payment on the patient side. Either they're going to pay a copay or a deductible or what have you, or the rate's going to be reflected by these different services. The other thing is it's going to reward providers for more services, whether or not the service is warranted. So instead of maybe trying to manage conditions medically, maybe you want to do a procedure, right? It actually rewards a provider. They're bringing more money in by doing more procedures. With the prospective model, there's an incentive to use less expensive procedures and tests. There's also an incentive to delay or deny procedures or treatments. Then finally, there's, some would say, premature discharge in the inpatient setting. And now we get into risk-adjusted coding, which is the CMS hierarchical condition categories, or HCCs. And basically, if you could visualize it this way, let's say your typical Medicare patient has a risk-adjusted score. In other words, you're saying how much the typical Medicare patient in a Part C plan would cost. So let's just say it's hypothetically 1.0 if they have no other comorbidities. Now we have other demographics. Let's say they're not just 65, let's say they're 95. Let's say they have a history of cancer. Let's say they have hypertension, right? The last three is going to drive the risk-adjusted score up. So in this kind of model, the insurance company will be getting paid by CMS a higher amount than if they were just a regular 65-year-old Medicare patient. And again, with risk adjusted coding, patients have to have a face to face visit at least one time a year between January the 1st and December 31st of the calendar year. Patients are seen by physicians and their conditions have to be documented, right? Captured and addressed. So this gets into coding. Coding, we want to know whether somebody has a history of cancer, which is not a paying HCC, versus metastatic disease, which is definitely a paying HCC. So once we have their health status, these diagnosis codes and HCCs are sent to the Centers for Medicare and Medicaid Services, and the health insurance company gets paid based on the reimbursement that's set by CMS. The idea is that high quality provider documentation is required for HCC coding. Coders are ideal candidates for risk adjusted coder positions. This is the arm in Medicare finance that I used to work in. And you can see figure 4.7 in your book that talks about a case study for HCC documentation. Let's take a quick look. And again, this is a nice illustration of how HCC documentation coding translates into things. So again, working from the premise that somebody with a higher risk adjusted score will determine more reimbursement. We have a 74-year-old African American male with BPH, ongoing symptoms of frequent urination, stable diabetes, arteriosclerosis, below the knee amputation, history of present illness, patient's been experiencing frequent and urgent need to urinate. PSA test shows 5.0, PVR shows 120, ultrasound confirmed enlarged prostate, and they have a plan for LUTS associated with BPH, referral to oncologist to rule out prostate cancer. So we have the documentation, and we should have things that are being coded, as we see over here. Right, and as we'll see in our next example later in this week, these codes will translate into a risk score, which ultimately translates into reimbursement. So you can see the kind of abbreviated documentation over here on this column, but over here is much easier to diagnose and code these types of problems. So you can see here BPH with LUTS. This is in a paying HCC, urinary frequency, ICD-10 code R35.0, not reimbursable, R35.1, urinating at night, so on and so forth. None of these things are reimbursable until we get to here, where we get into the type 2 diabetes, the coronary arteriosclerosis, and so on. Right, these are codes, and then again, eventually this will drive the reimbursement. With accountable care organizations, this is a population-based model for healthcare delivery and payment, somewhat similar to these different types of things that we've seen with managed care. Some of the things that we see with accountable care organizations are the ability to manage patients, not just in the hospital setting, but across the continuum of care, home health, nurse care management, SNF, and so on. And it gives capability to prospectively plan budgets and resource needs based on a patient population. And again, this area relies on accurate ICD-10 CM coding in order to get data to manage accountable care organizations effectively. We can see here that we're assigning a beneficiary to a particular accountable care organization, as illustrated in 4.8 in your book, right? So again, it's not just a free for all where people are just getting reimbursed, but they go through some algorithms, right? So in an instance here, does the beneficiary have at least one primary care service furnished by a physician in the accountable care organization? If they don't, there's no reimbursement, right? Was there a greater portion of primary care services furnished by the accountable care organization's primary care clinicians? If yes, it's assigned, right? So we have all these little things that happen that rely on appropriate documentation. And again, we talk about one-sided risk and two-sided risk. Accountable care organizations share savings when Medicare, when expenditures are less than expected. So in other words, if you plan things out right and you're not spending so much money, the accountable care organization benefits. The accountable care organizations are not required to share in the loss when expenditures are greater than expected. With the two-sided risk, accountable care organizations share savings with Medicare as expected, and then ACOs also share in the loss when expenditures are greater than expected. So it's not just one-sided. It's not just going all on CMS. I'm going to let you do these illustrations on your own, but let's take a quick look at figure 4.5. Sorry about that, struggling to find the figure. So pre-op clinic visit, $250. The surgery, $8,500. The routine post-op charge of $5,430. So using the same type of rationale for Olivia's situation, where she has her insurance company, SuperPair, reimburses the OB group with a global payment methodology. And going back to our earlier example, they get one amount covering the entire episode of care. Let's take a look at what this is going to look like. You can see here the prenatal component of it, 7 visits in weeks 4 through 28, weeks 28 through 36, the total of 4, 36 through 40, total of 4, total visits are 15, total charges are 2,625. The delivery charge, if it's a vaginal delivery, 8,775. Cesarean delivery, 12,687. And then the routine postpartum, 1 visit for a vaginal delivery, 2 visits for the C-section, and then here are the associated charges. So for the reimbursement for vaginal delivery, 6,610. Reimbursement for a C-section, 8,970. So again, this is the amount that the insurance company will reimburse the group. Olivia is responsible for all cost-sharing amounts based on what her insurance policy will do. And that's all I have for you. Come back for our next set of lectures on the HCC reimbursement model. I'm sure you'll find it very interesting and something that's growing in importance with insurance reimbursement. We'll see you online. Bye now.